everyone, we're going to get started. Please grab your seat. Good afternoon. My name is David Adelia. I'm the current president. Wow. Is there a cricket? I'm the president of the American Constitution Society here at Mauer School of Law. If you're unfamiliar with our group, the American Constitution Society is the nation's leading progressive legal organization with over 200 student lawyer chapters and student chapters across the state and on most law school campuses. Originally formed as a progressive response after the Supreme Court's Bush v. Gore decision, ACS was founded on the principle that the law should be an impact on people's lives and to improve the lives of all people. We also have some excellent events planned this semester, and we hope you can join. Please see me or a member of our executive board, which are incredible, to get on our mailing list. Today, we are pleased to welcome Ms. Regina LaBelle to Mauer, who is here to talk about the origins of the opioid epidemic and the pending multi-district litigation against Purdue Pharma. Regina and I go back to 2014, and I'll tell you a little bit about that later. Ms. LaBelle is a former chief of staff of the White House's Office of National Drug Control Policy. At the Office of National Drug Control Policy, she oversaw the agency's efforts to address the opioid epidemic and other drug policy issues, including overseeing implementation of President Obama's National Drug Control Strategy. Currently, Ms. LaBelle is the director of the Addiction and Public Policy Initiative at the O'Neill Institute at Georgetown University Law Center. She manages a portfolio focused on the opioid epidemic, addiction policies, barriers to treatment for substance use disorders, public health approaches to drug policies, and how the law can promote access to treatment and support recovery. She is a graduate of Georgetown University Law Center and Boston College. She appears regularly on media outlets such as MSNBC and CNN. She also contributes regularly to national print media such as The Hill. Now that we're done with the formalities, I mentioned that Ms. LaBelle and I go back to 2014. We talk about the legal profession a lot here at the law school and how much network is important. Regina gave me my first job out of college coming out the University of Illinois in 2014. She's been an amazing mentor of mine. Without her, I wouldn't be able to stand up in front of you here today. So without further ado, I'd like to welcome Regina.
Thank you. Good afternoon, everyone. I'm glad you could be here today. And I appreciate the opportunity to come to Indiana, and it's always nice to get out of D.C. And as David said, and I really enjoyed working with David because what we really tried to do at the Office of National Drug Control Policy was, and in the Obama administration writ large, as all administrations do, is to identify young talent and to bring them along and to potentially mentor them so that they go on to public service. Because I think, I've spent my entire life in public service. I worked, as David said, for a mayor and for the president for a total of about 16 years of my career. And it was the most rewarding aspect of my career was working in public service. And most public servants are very mission driven. And so as you're thinking about what you want to do in the future, I hope you'll contemplate a career in public service because it's very rewarding, if not financially, from a soul perspective. So what I want to talk about today, which is what David mentioned, is the origins of the epidemic, so of the opioid epidemic, how we got here, where we're going, and then I will also touch on the multi-district litigation. I am a policy person. I am trained as an attorney. I am licensed to practice law. However, I am not a bankruptcy lawyer. There are issues and aspects of the opioid litigation that I will touch on, but I will not go into great detail, again, because I'm not a bankruptcy lawyer. But I have spent a long time working on the policy issues relating to substance use disorders and the opioid epidemic, and that's what I really want to talk about today. I have no conflicts of interest to report. However, for 2 years ago, I was retained by a plaintiff's firm to advise them on their early litigation against the pharmaceutical industry. So that's my only conflict to report. So I began at ONDCP in the fall of 2009. There were many issues facing the country, as you may recall. And at the Office of National Drug Control Policy, our job was to develop a strategy to guide the nation's drug policy. And I put this picture up here because it really was reflective of how I felt when I walked in. Not only because I had a 7-year-old and my life was filled with Legos when I was not at work, but also because I felt like we were putting together a puzzle of how drug policy should go moving forward. We were tasked with reforming drug policy, but also within the confines of a lot of years of laws and policies that made it a challenge to develop a new approach to drug policy. So all the pieces were there, but we had to put them together. We had to expand healthcare. We had to build the treatment infrastructure and develop an addiction workforce. At the same time, our mission at the Office of National Drug Control Policy was to disrupt illegal drug trafficking, both domestically and internationally. Now, the Office of National Drug Control Policy is an office within the Executive Office of the President. They did policy. We did not bust down doors. It's not the Drug Enforcement Administration, but the office oversaw all of the policies relating to those issues. So there was a lot to be done when we walked into the door. And one issue that was facing America was drug overdose deaths. So this is a map of drug overdose deaths as it looked in the country in 2009. According to the Centers for Disease Control and Prevention, at the time in 2009, there were approximately 20,000 overdose deaths. Opioid overdose deaths in 2009 were the #1 cause of accidental death in the country, surpassing car crashes and firearms. And that remains the case today. Except today we have 70,000 overdose deaths in the United States, as opposed to 20,000, which was the case when we walked in 2009. This was 4 times the number of overdose deaths since 1999. And there were 3,000 of overdose deaths involved heroin, 10,000 were prescription drugs, and about 3,000 were from synthetic opioids classified as fentanyl and tramadol. But there was a deafening silence about this issue at the time. When we walked in, we were handed this problem to address because that's what our job was. But the national media really was not paying any attention to this issue. Opioid prescribing rates were also on the rise. And this is a map of prescription sales that were booming across the country. This didn't just happen in 2010. It was beginning in 2000 and over the course of the next couple decades. So OxyContin, which is the extended release formulation of oxycodone, was introduced to the market in 1996. It's a long-acting opioid that is supposed to last for a longer period of time. So in theory, you didn't have to use as much. It was supposed to be used for 10 hours, but it really was not necessarily relieving pain for that long, so people were using more of it. From 1997 to 2002, OxyContin sales went from 680,000 to 2 million prescriptions. And I remember this very distinctly, the incredible rate of prescribing that was going on in the state of Florida. So the Drug Enforcement Administration, DEA, reported that 90 of the top 100 oxycodone prescribers in the country were in Florida. And a lot of law enforcement attention was being paid to what really were pill mills, where doctors would come in the morning, they would sign prescriptions, they would hand them out to the hundreds of people standing in line for the prescription. There were no questions asked. It was a rogue operation. So the Drug Enforcement Administration spent a lot of time with local law enforcement bringing cases and closing a lot of these pill mills. But you could see what was happening was affecting all up and down the East Coast. So the number of oxycodone tablets that were prescribed in Florida was really feeding the overdose epidemic in Appalachia and in Florida as well. So as I said, there was a deafening silence on this issue, but most people understand that there were a lot of other things going on at that time. In 2009 and 2010, the U.S. economy was in a shambles. Unemployment was on the rise, and there was a stimulus package that was getting out. And this is a list of the issues that were being discussed at the time in the national media. And you'll notice the absence of the #1 cause of accidental death in the country wasn't being discussed. Is there a cricket in here, or is that a phone? So we were, we were tasked with reforming drug policy, but you don't come to these jobs in a vacuum. You come kind of with all the years of work that's been done on the issue in the past. And I know this might shock you, but political science often had a lot more to do with drug policy than actual science did. There were people who believed that we should allow people to overdose because it would shock them into seeking treatment. That is not the case, but there were people who believed that. There were people who believed that providing syringes to individuals was like handing someone a gun to shoot themselves, instead of examining the body of evidence that exists where we know that syringe services programs reduce infectious disease relating to injection drug use. That's just a scientific fact. But we were faced with that. And then we also, nationally, so it wasn't just, policy makers often reflect the populace, right? So fewer than 1 in 5 Americans were willing to associate with someone who had a substance use disorder because it is perceived as a moral failing, like something you don't want to be around, even though we know there are 23 million people in this country who are in recovery, and there are 20 million people in this country who have a substance use disorder. So chances are you know someone with a substance use disorder, but you really would rather not talk to them. So these are the issues that were reflected in kind of the undercurrent of the environment we were introduced to. In addition, there were high-level policymakers who opposed naloxone distribution. Naloxone is an opioid antidote that reverses an overdose. And there had been decisions made at the national level in the past that we should not promote the distribution of naloxone because, again, maybe someone needs to overdose in order to enter treatment or enter recovery. So in 2011, we worked for a couple years, beginning in 2010 when we did a tour of Appalachia. Went to Kentucky, West Virginia, and Georgia to see firsthand what was going on in these areas of the country and how we could help. And we did that, this is a very bipartisan issue. We did that with Senator McConnell and with Congressman Hal Rogers, who is from a part of Kentucky that's been very affected by the opioid epidemic. So we released the Prescription Drug Abuse Prevention Plan. Now this was, again, at the time, it really was focused on prescription opioids, not heroin. And the plan had 4 pillars. The first pillar was educating parents, patients, and prescribers about opioids, how to use them properly, and the risks associated with misusing them, because we knew that many young people, many parents from surveys at the time didn't see that there was any risk associated with misusing prescription opioids, and actually there were parents who believed that it was better for them for kids to misuse prescription drugs than another type of drug that they might get from someone else illegally. We also included expanding prescription drug monitoring programs. Prescription drug monitoring programs are now in all 50 states. At the time, they were in about half. And the intended purpose of prescription drug monitoring programs is so that prescribers can know the totality of prescriptions that an individual has been prescribed, so that they can intervene with that individual if he or she has early signs of misusing prescription opioids. That's the intended purpose of them. And third, increasing proper disposal, because we know that over 50%, even today as then, 50% of people who begin misusing prescription opioids get them from family or friends. So there was basically people hang on to prescription drugs, and so we wanted to make sure that people understood that you should dispose of your prescription drugs, particularly opioids, and not keep them hanging around where they can be misused. And then lastly was an increased effort to decrease rogue pain clinics, particularly in the Southeast, that were cropping up in the Southeast. So the plan also was not a standalone plan. It accompanied the Affordable Care Act and Medicaid expansion, because we needed to increase access to treatment for substance use disorders. But at the same time, there was little new federal funding that was added, and a few federal laws were passed, including a law that allowed for the Drug Enforcement Administration to increase access to disposal programs nationwide. And that law was passed, and now, for example, in a state like Washington, Oregon, and in certain parts of California, pharmaceutical companies have to pay for the disposal of the prescription drugs that they manufacture. So it has increased, in many states, it's increased access to proper disposal. And then also, as a result of this, states expanded prescription drug monitoring programs, and Florida's prescription drug monitoring program began in 2011. So we implemented this plan, and at the time we had about 100 people dying every day. Also, as part of the plan, included an extensive effort to kind of normalize naloxone and to get naloxone in the hands of individuals who may be at risk for being around someone who might overdose. We sought to expand it initially through law enforcement avenues, and there were a couple reasons for that. One reason was because the epidemic was really affecting rural parts of the country first, and in that case, law enforcement is often the first responder. They'll show up first on the scene. So if they were equipped to save a life with naloxone, that was one way we thought we could help the problem, particularly in rural America. And the second reason we began by engaging law enforcement was because we felt that if we start with law enforcement, we're not going to have that same argument about how this is enabling drug use. That first and foremost, if we get law enforcement to see that saving a life is in and of itself important, that's worth doing. So we started with that avenue first. In addition, states also had to pass Good Samaritan laws so that people would not be afraid of calling 911. If you call 911 and you are on site, we wanted to make sure that people knew that they were not going to be arrested. So Good Samaritan laws was also an important piece of this plan. And then thirdly, states also passed standing orders to allow more naloxone distribution beyond just to the public, and again to people at risk for being around someone at risk of suffering an overdose. So there was a brief shining moment where we had a decrease in prescription opioid overdose deaths, and they dropped for the first time since 1999. And as shown, and this is a Centers for Disease Control and Prevention graphic, it shows the rates of opioid prescribing were going down. Each of these states implemented various practices. So New York passed a lot of laws that allowed, that made sure that these rogue pain clinics could no longer operate. One of the laws that they passed said that if you are dispensing, you can't dispense opioids at the same place that you're prescribing the opioids, because basically it was becoming a one-stop shop in Florida, and all of the regulatory processes that are put in place to prevent rogue prescribing were thrown out the window. So those things were changed. And Tennessee also passed some laws. So we had this, a good day in this time period. There was also a reformulation of OxyContin in 2010. And the reformulation of OxyContin meant that OxyContin was an abuse deterrent formulation. It was the first opioid to receive an abuse deterrent formulation. An abuse deterrent formulation basically means that it cannot, if you crushed it to snort it, you couldn't do that. So, and some studies pointed to the fact that there was almost a 40% reduction in opioid misuse of OxyContin between 2010 and 2014. But the reformulation and all these laws didn't make people with opioid use disorders disappear. Because at the same time, we didn't have an increase in treatment availability in this country. Even with the Affordable Care Act and Medicaid expansion, we have a shortage of treatment providers, and most importantly, a shortage of treatment providers who provide the medications that are shown to decrease overdose deaths and help people enter recovery. So the Centers for Disease Control and Prevention has referred to this as the 3 waves of the rise in opioid overdose deaths. I think this is a nice graphic, but the one thing to keep in mind is that the waves in and of themselves, it's more like a layer cake. They layer on one another. So the number of people dying from prescription overdose deaths, again, didn't disappear. People went to heroin. So the second wave of the overdose epidemic in opioids has been an increase in heroin deaths. Heroin-involved overdose deaths more than tripled between 2010 and 2014. So we had an increase in supply, and we had an increase in demand because you had people who began at the time, began with a prescription opioid, and again at the time, went to heroin. So again, when we say that people didn't disappear, the graphic I want to, this is the treatment gap, which was in 2014. So, and a lot of this remains the case today. So about 10% of people with a substance use disorder receive treatment. For opioid use disorders, it's higher, so between 30 and 50%. This is according to the National Survey on Drug Use and Health. So again, when we say that people didn't just go away, they may have overdosed, but their condition remained untreated. So there were a few things that we saw as a result of the second wave, as we entered the second wave of the epidemic. Heroin use was increasing among most demographic groups, but in particular, it was a younger cohort, more white people, and female, in places where syringe services programs weren't available. So injection drug use was going up in areas of the country where we hadn't seen it before. And so as a result, we saw a rapid increase in hepatitis C and HIV around the country, directly related to the lack of syringes and injection drug use in many parts of the country. In addition, we have seen increases in neonatal abstinence syndrome. Neonatal abstinence syndrome is what newborns experience when they are exposed to opioids in the womb. I just want to say one thing about this. Infants are not born addicted. So if you read this, it says the baby's addicted. Babies cannot be addicted. Addiction is a volitional act. They are exposed to opioids. That may seem like a fine point, but it's important when we talk about stigma, because stigma is involved in every single aspect of this issue. So neonatal abstinence syndrome is driving up hospital costs, medical costs, and there was some research being done about how best to treat infants, and actually what they found, the best way to treat the infant is to keep the infant with the mother in their room, to have that warmth, to have the baby with the mother, not to necessarily medicalize this, and to get the mother the treatment that she needs. So this is, these were all occurring at the time. So we had heroin use increasing, injection drug use increasing, neonatal abstinence syndrome increasing. All these consequences are happening around the country. And then we entered the third phase of the epidemic, which involved fentanyl. So fentanyl is, and I'm not talking about fentanyl patches or fentanyl lollipops, which are illicit fentanyl that you get from a doctor, usually for end-of-life care. This is primarily illicit fentanyl, fentanyl that is mixed in with heroin. And this is a slide that was taken from 2014 Drug Enforcement Administration data. So it's seizure data where they see that the fentanyl that they're seizing is primarily east of the Mississippi. And we were seeing death rates in Ohio, Massachusetts, several other states. 70–80% of opioid-involved overdose deaths, the individual had fentanyl in their system. The reason why fentanyl is more prominent east of the Mississippi than west of the Mississippi is because of drug trafficking patterns and the type of heroin that is available east of the Mississippi. Fentanyl is easier to mix. West of the Mississippi, not as easy to mix. But what we're recently seeing the last couple of years are fentanyl pressed into pills and sent out and given to people as OxyContin. But still, the majority of fentanyl-involved overdose deaths at this point are east of the Mississippi. So this is, again, the third wave of the rise in opioid overdose deaths. Fentanyl-involved overdose deaths kind of began in 2013, but really took off in 2015. But I'll tell you that the coroner data, the medical examiner data that the Centers for Disease Control and Prevention relies upon to do this type of analysis isn't perfect. And the testing that goes on around the country is not great. So we may have seen fentanyl-involved overdose deaths may have been higher in 2013. And there's been some research to show that that might be the case, but this gives an indication anyway of kind of the trajectory of the issue, if not perfect. So it took a while to get the public's attention, and the press started covering the issue. And in 2015, there was an increasing call for action by the federal government. A couple things happened in 2015. Working with Congressman Hal Rogers, Republican from Kentucky, as well as with Senator McConnell, language was added to the Appropriations Act, the Health and Human Services Appropriations Act, to allow federal funds to be spent on syringe services programs for everything but the syringes. So we got them that far. It was a lot of work that was done to discuss this issue primarily with Congressman Rogers to make sure that he understood how this could affect the people of his home state. And because also at the same time, the Centers for Disease Control and Prevention put out a vulnerability index to show that many counties in Kentucky were at risk for having Scott County-like outbreaks. Scott County, Indiana, which I'm sure you're aware of, had an outbreak of Hep C and HIV. And so we were fortunate at least to get them to that point. Now the state of Kentucky has 50 of its counties now have syringe services programs. And they're not perfect, they're not open all day, they're not open as much as they are. but it's becoming, harm reduction in the state of Kentucky, in the Commonwealth of Kentucky, has become a real public health, public safety effort in that state. At the same time, the Centers for Disease Control released its opioid prescriber guideline for chronic pain. And the guideline was intended to educate prescribers about opioids, about pain management, etc. And so that was put out also in 2016. In addition, two major pieces of legislation were passed. The first was the Comprehensive Addiction and Recovery Act. That passed. That was mostly a policy piece, so that authorized a few things that I'll discuss in a second. And the second bill was the 21st Century Cures Act. This was the last bill President Obama signed into law in the last couple months of his administration. So the Comprehensive Addiction and Recovery Act has several policy provisions that are important. First, it allows advanced practice nurses and physicians' assistants to prescribe buprenorphine. Buprenorphine is one of the 3 FDA-approved medications to treat opioid use disorder. It authorized new grant programs for naloxone distribution, recovery, and treatment. It also increased VA oversight of opioid prescribing, and then lastly allowed for partial fills of opioid prescriptions as allowed by under state law. The 21st Century Cures Act was a comprehensive piece of legislation that included $1 billion, authorized $1 billion in funding to close the treatment gap that we talked about before. So the purpose of the $1 billion that was authorized in the 21st Century Cures Act was to make sure that individuals who sought treatment but were unable to receive it could obtain it. So these authorizing statutes then had to be considered and included in the budget, and they were both included in the fiscal year 17 budget. $1 billion was appropriated in the FY17 budget to be sent to states, and then another about $188 billion was appropriated in order to pay for some of the grants that were authorized under the Comprehensive Addiction and Recovery Act. So in 2017 was really the first year we saw a considerable amount of money being sent to states to deal with the opioid issue. $500 million plus additional funds were sent to states under what's called the State Targeted Response Grants. So states like Indiana had to send a plan to SAMHSA and say, this is what we're going to do to close that recovery gap for opioid use disorder. And the CARA program also had a number of grants that were competitive grants that various states and local governments had to apply for. So then this continued, the effort by Congress and the administration continued into 2018. In 2018, additional funds went to states, including $1.5 billion. So we went from $1 billion to $1.5 billion for these state targeted response grants. The grants, so the new grants for FY18 are intended to build upon the money that went in fiscal year 17. And states are now required, if they fund a treatment program, that treatment program must allow and has to use one of the 3 forms of medication. It doesn't force people to use the medication, but if you're going to treat someone, if you're going to use federal money to have a treatment program, you must use one of the 3 forms of treatment medications. And then in 2018, the President also signed H.R. 6, which is the Support Act. It's a very big bill, but I'll give you some highlights. It permanently authorizes advanced practice nurses and physician assistants to prescribe buprenorphine. So if you're a physician's assistant or advanced practice nurse, you take a 24-hour training as opposed to an 8-hour training that a doctor has to take, and you can prescribe buprenorphine for an individual. And actually a lot of advanced practice nurses and physician's assistants have chosen to take this route to treat people with opioid use disorders. It also allowed for states to have Medicaid plans under their Medicaid plan to provide inpatient treatment in facilities that had over 16 beds. So there's a limitation on the number of treatment beds you can have. This allowed for a limited time plan amendment for people to go above that 16-bed treatment limit. Beginning in 2020, it allows for Medicare coverage of methadone to treat opioid use disorder. And it also had authorized a loan repayment program for the addiction treatment workforce. And that now, this year, is when that money for that is being included in the budget to fund that program. So I want to go back to the 3 waves. This has really been a bipartisan issue. Most of the legislation that's passed in Congress is passed with overwhelming bipartisan support. And earlier this year, there was some discussion about, have we turned the corner on the epidemic? So early indications from the Centers for Disease Control show that nationwide we're down about 3%. So the 2018 final data will be released later this year, but early data show a 3% decrease. Higher in some states than others, up in other states. So a good sign. It's better than going up, but we're not at the end of this yet, and 3% should not be considered a victory lap yet. But a few states have implemented some really great programs that are making a considerable difference. For example, Rhode Island introduced a medication program for anyone who is incarcerated in that state who has an opioid use disorder can be put on one of the 3 forms of medications to treat their opioid use disorder. That program decreased overdose deaths among the reentry population. So upon leaving incarceration, that's one of the highest risk groups for overdose are people leaving incarceration. They decreased overdose deaths among that population by 60%. And 12% in the state overall, just by doing this program for people who are incarcerated. So also the nation, we've decreased rates of opioid prescribing, rates have come down, and we've seen federal investments being made, but I still believe that there is obviously much more that can be done because we still don't have a national treatment system that can be responsive to the entirety of addiction in this country. So I want to switch now to the multi-district litigation briefly, and then talk about, again, from a policy perspective, talk about what some of this funding might be used for if we really are to make a dent in the issue. A couple just level setting for everyone in the room. There's probably people who know a lot more about this, but I want to make sure we're level set. So the multi-district litigation is not a class action. So it is similar to the tobacco litigation because it has a large national import, but is not a class action like that was. It's multi-district litigation, and in December of 17, these cases were transferred to the Northern District of Ohio. The cases are being heard now before Judge Polster, and bellwether or test cases are going to be heard in October. October 21st is when the test cases start in Ohio. The cases that will be heard are Cuyahoga and Summit counties, and these were chosen as bellwether cases because they were highly affected by the opioid epidemic and also should be reflective of the rest of the cases. The trial is supposed to last 2 months. There's a lot of going back and forth about the extent. There are a lot of defendants who are complaining that that's too short. There are 13 defendants in the case right now. There are settlement talks that are ongoing, however, which I'll get to in a second. But the judge also recently approved a settlement class. So 2,000 cases have been filed by local governments, and the 30,000 cities, counties around the country are part of this group. And so they're trying to broker the settlement of these cases for the entirety of those cities. And they break down the voting based on the population, but also whether or not you are part of the litigation, because there are cities, counties that are not part of the litigation that are included in the settlement class. And if you're interested in this, they have a really an interesting URL website where you can look at, click on your county, and if the settlement is for $1 billion, if you click on your county, you can see how much that county would get of the $1 billion. That's opioidsnegotiationclass.info. But this issue is shifting on a daily basis. In this summer, so many of you probably heard about this summer, the Oklahoma case against Johnson & Johnson, in which the judge ordered Johnson & Johnson to pay over $500 million for abatement. Now, the abatement was just for 1 year, not for everything that the state had asked for, primarily because they said that they couldn't prove all the damages going forward. So this was based on a public nuisance statute, very unique to Oklahoma, and it was a bench, not a jury trial. North Dakota, earlier this year, had a public nuisance statute that was thrown out in its state because their statute was different than what was occurring in Oklahoma, than what they had in Oklahoma. Johnson & Johnson has, as to be expected, filed for an appeal, and the appeals process on all of this may take years, which is why the co-lead counsel for plaintiffs suing Purdue in the multi-district litigation, he said that he wanted to accept the settlement. Now we're shifting to the Purdue case in the multi-district litigation. And Purdue's kind of the poster child because they made OxyContin, right? They're the one company, although they probably of all the companies have the least amount of money available and resources. Johnson & Johnson is a much larger company than Purdue. So the co-lead counsel for plaintiffs suing Purdue encouraged his clients to accept the deal, the offer that Purdue made to them, which I'll get to in a second. He said in a Post article, it's a better bet than the alternative, which he called probably a decade or more in bankruptcy court, at the end of which will probably be a ham sandwich left over for our clients and the communities that are suffering. So the plaintiffs in this Purdue litigation have to decide whether they want to hold out for more or if they're happy with what they're currently being offered from Purdue. And this is what they're currently being offered. The settlement is worth between $10 and $12 billion, including $3 billion from the Sacklers over a 7-year period, the proceeds from the sale of one of their other companies, Mundy Pharma, and the rest of the money would come from Purdue. The Sacklers are the owners of Purdue. They would no longer own Purdue, but Purdue would sell the opioids, and any proceeds from that would go towards settlement. Purdue would also provide in-kind opioid treatment drugs. There are many who question whether or not that amount is really worth 10 to 12 billion, given the speculative nature of future sales, as well as the speculative nature of the value of Mundy Pharma. But the kicker in all this is that the Sacklers want to be shielded from any personal lawsuits. So 29 states have agreed to that deal. 29 attorneys general have agreed to that deal. But states such as Massachusetts, New York, Washington, and Connecticut have said no. And actually the state of New York has filed against the Sacklers. But the local governments have all agreed. And there are people who are, a lot of family members, a lot of people who lost loved ones really want to see Purdue held to account. And I know that torts attorneys say this all the time, plaintiffs' attorneys say this all the time, that it's not just about the money. But in this case, I think that a lot of people are holding out, are saying, I want to see Purdue have to pay a little more, but also I want to get an apology from them. And I want them to face what they did. So that's kind of what's going on in this space right now. There are people in the recovery community very outspoken, organizing against the Sackler deal, what they perceive of as a deal with the Sacklers, and that would shield them from further litigation. But Purdue is only one of the cases. The multi-district litigation also involves CVS, Walgreens, Mallinckrodt, McKesson, many other drug distributors. And the plaintiffs all had to file abatement plans where they calculated the costs to abate the opioid problem. So the question is now, how will the money be allocated? And also the question that no one really talks about is, what's it going to take? How much is this going to cost? And so the Senator Warren and Congressman Cummings is from Maryland, they've introduced the CARE Act. They estimate $100 billion over 10 years that it will cost to abate this. So this is just the overview of what, if you look at the continuum of care, each of these, we don't have a system in this country to deal with addiction. Now, I don't believe that the people who created the opioid epidemic need to pay for the entirety of the continuum of care, but I do think they have a role to play. But when we think about this, it's not just one thing. It's all of this. It's creating a prevention system, a treatment system that is medically based and evidence-based, a recovery system that includes other services that people need to sustain their recovery, such as housing. And lastly, that we look at harm reduction, that we make sure we don't have a bake sale approach to our addiction system in this country, which is really what I think we have today. And that people are taking the crumbs off the table, and anything else, any other disease in this country, we don't treat it like this, but because what we talked about at the beginning, there's such a stigma attached to it, we really have taken a bake sale approach to what's a very major issue in this country that we all have responsibility for fixing. So thank you very much for this opportunity. I know we want to get to questions. I think just one thing that I want to say, I'm thinking a lot about this, that how do we get from where we're trying to rescue communities to building communities of recovery, healthy communities with healthy outcomes, where we're not only focusing on today's crisis, but also looking towards building a community of recovery. So thank you very much.
So we have a little time for Q&A, so just wave your hand in case you need the mic over to you.
Thank you for being here. I have two questions. I can't pick between them, so I'll ask them both quickly and see if that works. So one, we have a special interest in Mike Pence here, former governor, and the Scott County example. And I was glad to hear you say now a lot of this is bipartisan. And I'm wondering in particular if you know if Mike Pence has changed his view adequately, and he's someone who was at least partly responsible for the Scott counties. The other is, I hear anecdotally from patients and doctors that, this is a huge problem and all this is very needed, but that there are some costs, there are some cases where patients aren't getting drugs they need, pain relief, and doctors who say they have patients who, under this regime, they cannot prescribe for. And like one anecdote is that a new patient treated in Bloomington who drives from a rural area 2 hours away with horrible, excruciating, infection in their spine, this is just one example, cannot get the pain relief they need without the impossibility of returning. So I understand that might be a tiny cost, but I wonder if you think it even is a cost. Are we adequately dealing with people who need the pain relief?
Yeah, I think those are two great questions. I'll answer the first one quickly first. So I can't speak for Vice President Pence, but I can speak to the administration. The Health and Human Services Department has made a real priority addressing a 20-year plan to address HIV/AIDS. I've met with the Assistant Secretary of Health, Brett Girard, who is kind of he calls himself the tip of the spear in HHS for all things opioids. I asked him specifically, are you all going to expand syringe services programs around the country, because your voice is really needed in communities where they might be reluctant? And he said absolutely, and they have backed that up. There's always more that can be done, but I'm going to take them at their words. I don't really have much of a choice right now. So that's what we'll do. And on the second piece, I think that you raise a really important point, and this is where one of the responses that policymakers, state legislators came up with was a 3-day limit on opioids. And I remember distinctly when that came up, I said, oh, I really don't like that, because doctors then, it's not empowering the medical community to be part of the solution. So we need better pain management. People who need opioids should not be denied opioids because of, a concern, or they need to screen properly and they need to treat people properly. And so we do need that balance is critically important. And I am afraid, so the CDC put out its opioid prescriber guideline and then clarified them this year for that exact reason. It's because doctors were like, well, I can't prescribe to anyone. And, so I'm not a doctor, I just play one on TV. But I will leave that to the medical community and the American Medical Association to lead on that issue, because they need to.
Sorry, I also have 2 questions. The first is, at the local level, you had touched on the importance and the need for housing sort of in the recovery period. And I'm wondering if you could talk about the efforts or the issues that municipalities are facing when it comes to zoning and how to integrate some of these kinds of group homes or transition homes around the country. And then the second question I have is whether you can speak to the role that the private sector has in supplementing the treatment program. I know that there's a lot of venture capital money that's being put into treatment programs, and I'm wondering how that interfaces with the federal regulations to address this issue.
Yeah. So the first question is, I think there are 2 pieces to this. One is that every time, I know someone who runs treatment centers who said every time she wants to open up a methadone program in a neighborhood, she gets the whole neighborhood to just, to oppose it. And it's horrible. And they have a whole full-time, law firm working on this issue. So again, that goes back to, it's astonishing to me, the more you get into this issue, the more you see in stark relief the stigma. Because that is just stigma, that's all about stigma. If it were anything else, the neighborhood wouldn't be complaining about it. But because it's attached to drug addiction and treating people with drug addiction, there's that stigma. And there's no evidence to show that there's an increase in crime relating to methadone clinics or even recovery houses. But the second piece is standards for recovery houses. This is a whole huge industry that is opening up with very little regulation at the state level, even less at the local level. What is a recovery house? Really, what is it? How is it? How should it be regulated? What are the zoning? The zoning, and that also bumps up against the ADA. So there are some model recovery acts that are coming out now that are looking at that. What should recovery programs look like? The National League of Cities is doing some work on that. So I don't have a great answer right now, but I know that the first part we can, mayors can lead by saying these people are members of our community and we need to embrace them. And that can potentially help with the stigma. And then the venture capital piece, I welcome private sector investment in this with regulation and parameters to make sure that people get the quality of care. But so Shatterproof is a national organization that works on addiction. They are issuing kind of treatment guidelines so that we know what is good treatment. What does it look like? What should the aftercare look like? Because we have, and also to make sure that federal funding is not going to programs that have no evidence base, like equine therapy. You know, these are not things that have evidence base. The feds shouldn't be paying for them, and neither should the states.
Well, I want to thank Regina again for coming all the way to Marlboro.